Yes, we are live on YouTube now.
So can you see my presentation?
Yes, ma'am.
Yes, ma'am.
Just have to do a full screen.
Okay, so before I begin, let me thank Nephrocon for giving me the opportunity to present here. The topic which is given to me is on Alport syndrome. So my talk will have following outline: introduction, epidemiology, pathophysiology, genetics, clinical feature, light microscopy findings, immunofluorescence study, electron microscopy, diagnosis, prognosis, and differential diagnosis. So in 1927, Alport first described hereditary nephritis as genetic condition with abnormal kidney disease, hearing loss, and eye deformity. And this was due to the defect in the basement membrane type 4 collagen due to the inability to form its isoform alpha 3, alpha 4, alpha 5 due to mutation in the genes encoding this isoform. Call for A3, call for A4, call for A5, which reduces the tensile strength of the basement membrane and causing the symptoms. Alport syndrome is rare but most common form of the inherited renal disease. It is seen in 1 in 5,000 in the United States, 1 in 50,000 in Europe and India. So most common pathogenic variants are call for A3 and call for A5. Renal disease in young, end-stage renal disease in the young should raise the suspicion of Alport's disease. Males are more commonly affected than the females, as X-linked inheritance is the most common pattern of mode of transmission. So Alport syndrome can have varied mode of inheritance. It is linked to the X chromosome, sex chromosome, as well as the autosomes. X-linked inheritance being the most common, that is in up to 80% of the patients where males are more severely affected, but females are as carrier due to the inactivation of the other X chromosomes or lionization of the other X chromosomes. When inheritance is autosomal, it can be dominant as well as recessive. It can be homozygous as well as heterozygous. And there is one more mode of inheritance called digenic, which is the combination of the above. In X-linked abnormal gene is call for A5, while in others it is call for A3 and call for A4. Now, depending on the mode of inheritance, various phenotypes and genotypes are seen in the Alport syndrome. If we see in this particular figure, autosomal dominant inheritance, they usually present, they have milder clinical presentation as compared to the X-linked inheritance, where the severity of the symptoms are more. And in between, we have the presentation of FSGS and the other milder symptoms. Pathophysiology. Now, normally, in the immature glomerulus, we have alpha 1, alpha 2 type of isoform of the type 4 collagen, which is replaced when the capillary starts forming in the glomeruli by alpha 3, alpha 4, and alpha 5 isotypes, and giving the good tensile strength to the capillary basement membrane. But what happens in the Alport syndrome, this particular replacement of the alpha 1, alpha 2 isoform by alpha 3, alpha 4, alpha 5 isotope does not occur, and hence there is a weak basement membrane having basket weave appearance and causing the various symptoms. So in kidney, what we see is, in kidney, we see varied thickening and thinning and splitting and lamination of the capillary basement membrane. In the ear, inner ear, we see the damaged hair cell which causes sensory neural deafness. In the eye, what we see is dull macular reflex and dot and fleck type of retinopathy. The most common feature of the Alports is anterior lenticonus and oil droplet sign in the eye. The clinical features in Alport syndrome, the age of onset can be any time ranging from infancy to the late adulthood, depending on the severity of the mutation. Asymptomatic urinary abnormalities are also the common form of first presentation. Apart from that, we have intermittent gross hematuria, or sometimes they may be diagnosed first time with the hearing problem or the vision problem. And they progress gradually to have a microscopic hematuria, which becomes persistent from intermittent proteinuria and the symptoms of nephritic syndrome, and progressing to end-stage renal disease very early in the life, second to third decade. Sensory neural hearing loss, which is usually progressive, bilateral, affecting higher frequencies first, and they begin in late childhood or adolescence. Eye has oil droplet sign and anterior lenticonus in the Alport syndrome. Now, if we see in this particular figure, again, it is telling that based on the severity of the mutation and the type of the inheritance, there are varied symptoms from asymptomatic to microscopic hematuria to proteinuria, renal failure, and extrarenal features, and end-stage renal disease. So from this figure, if we can see males which are X-linked Alport syndrome, and males and female with autosomal recessive Alport syndrome, they have more disease severity and they progress to the end-stage renal disease faster as compared to the autosomal dominant heterozygous pathogenic variant and female X-linked Alport syndrome. So how do we go about the diagnosis? Most simple common one is the urine analysis to look for persistent microhematuria, mild proteinuria, blood test to look for the renal function test, then kidney biopsy. What do we see in the kidney biopsy? If it is, many of the times we see normal renal biopsy, but when patient has microscopic hematuria, young patient with normal morphology on the renal biopsy, we have to do the electron microscopy to look for the basement membrane changes and the diagnosis of the Alport's syndrome. When the microscopic hematuria and proteinuria persist, then the endothelial cell will stimulate the mesangial cells, which lay down the mesangial matrix and forming the segmental sclerosis. This is called focal segmental sclerosis, which is best seen on this PAS stained section. With more hematuria and the proteinuria, more progression of the disease, there will be tubular atrophy and the interstitial fibrosis, which is most commonly appreciated on empty stain. The most common feature of the Alport syndrome on renal biopsy is the presence of sheets of interstitial foam cells, which can be present in the cortex as well as at the corticomedullary junction. How do we detect abnormality of the type 4 collagen? On the immunofluorescence study, Normally, when we do the type 4 collagen immunostain, alpha 1 and alpha 2 type 4 collagens are present in all the basement membranes of the glomeruli, Bowman's capsule, and the tubules, tubules. In alpha 3 type 4 collagen, it is present in the glomerular basement membrane and the focal distal tubular basement membranes. In alpha, when we do alpha 5 type 4 collagen stain, it will be seen normally in the glomerular basement membrane, Bowman's capsule, as well as in the distal tubular basement membrane. When we see the patient with X-linked Alport heterozygous affected female, they will have mosaic pattern. That means the alpha 3 type 4 collagen and alpha 5 type 4 collagen will be having mosaic type of staining intermittent in the capillary basement membrane and the tubular basement membrane. However, alpha 1 and alpha 2 type 4 collagens, they are showing normal pattern. If there is a defect in the alpha 5 type 4 collagen, then there will be total absence of the staining in the glomerular basement membranes, but the Bowman's capsule stains they show the staining. On electron microscopy, then what do we see? We have to be very careful if we are looking for any abnormality of the capillary basement membrane on electron microscopy, then paraffin block is not the right tissue or sample for detecting the basement membrane status on the electron microscopy. So we should have a good tissue collected in the glutaraldehyde to look for the basement membrane changes on electron microscopy. So this particular figure is showing the uniform basement membrane thickness. If we can appreciate everywhere, this is the normal renal glomerular basement membranes. In case of the Alport syndrome, there will be different sizes of the capillary basement membrane. Here, if we see with the black arrow, this is the thinning of the basement membrane, and here with the red arrow, we can see the thickening of the basement membrane. Here, we can appreciate the thickening of the glomerular basement membrane along with the lamellation. There will be additional effacement of the podocytes as well as the microvillus formation. Again, here we can appreciate on high power the lamellation of the basement membrane and truncation of the external lamina externa, and there will be microvillus formation. So these are the different changes in the electron microscopy in the patient of Alport syndrome. Now, what are the other changes we can see in the patient with Alport syndrome apart from the renal, eye and ear changes? Premature thoracoabdominal aortic aneurysm and dissection can be seen again in the patient with X-linked Alport syndrome. When there is a mutation in the COL4A5, that is deletion, which extends into the adjacent collagen 4A6 gene, it can cause leiomyomas, and they can be leiomyomas can be also seen in the patient with the Alport syndrome. So nowadays, invasive methods like renal biopsy is not necessary. Genetic testing alone can also come to the diagnosis of the Alport syndrome. And which are the conditions when we should do genetic testing? In case of the persistent hematuria, proteinuric kidney disease, focal segmental glomerulosclerosis, podocytopathies, and renal failure of unknown origin. Or patient has inner ear hearing loss, In those cases, call for A3 and call for A4 may be included in the cystic kidney disease panel. When there is a basket wave type lamination of the glomerular basement membrane, irregular bulging of the glomerular basement membrane, thin glomerular basement membrane, electron dense deposit in the glomerular basement membrane, which are different from the immune complex mediated renal disease. In those cases, we should do genetic testing to confirm or exclude the Alport syndrome. Sometimes even skin biopsy is done instead of renal biopsy because it is easily done, and then they also show different type of collagen abnormality to confirm the presence of the abnormal collagen type 4. So this is the control and the autosomal recessive Alport syndrome, where we can see the normal staining of the basement membrane of the epidermis, and this is the female X-linked Alport syndrome carrier, where we can see mosaic pattern like how we saw in the renal biopsy, where here you can see the staining of the basement membrane of the epidermis, but it is absent in this area. And this is the male X-linked Alport syndrome, where we can see total absence of the basement membrane of the epidermis. The other diagnostic test for hearing, audiometry, ophthalmological examination. Most common differential diagnosis of Alport syndrome is thin basement membrane disease, which is usually seen in the early period of the Alport syndrome. It's a non-progressive condition due to the structural abnormality again in the glomerular basement membrane. But here there is no proteinuria and the disease is not progressive. And the thin basement membrane disease is suspected clinically if there is persistent microhematuria in the absence of proteinuria and no and impaired renal function and no extrarenal symptoms of Alport syndrome. Ultrastructural finding of thin glomerular basement membrane does not exclude Alport syndrome. So when we see thin basement membrane disease, we have to always look for the extrarenal symptoms or proteinuria and further follow up the patient for the confirmation or exclusion of the Alport syndrome. There are so many differential diagnoses apart from the thin basement membrane disease, which I have just listed here, difficult to cover now. So my take-home message is Alport syndrome is a rare but most common form of hereditary glomerular disease. It has a defect in the basement membrane type 4 collagen, one of the structural protein in kidney, eye, and ear due to the mutation in type 4 collagen gene called 4A3, A4, and call 4A5, causing renal symptom, sensory neural hearing loss, and eye symptoms. Most common is anterior lenticonus. Alport syndrome is both autosomal and sex chromosome linked inheritance, X-linked being most common, that is up to 80%. Males are affected more than the females. Severity of the symptoms are directly related to various mode of inheritance, further helps in knowing prognosis. Asymptomatic urinary abnormality and end-stage renal disease in young are the most common mode of detecting Alport syndrome with high index of suspicion. Morphologically, renal biopsy can be normal. Immunofluorescence stain for type 4 collagen, electron microscopy study from thin basement membrane to classical basket weaving pattern, and genetic testing for mutation in type 4 collagen genes helps in diagnosing Alport syndrome. Very important, paraffin tissue is not appropriate to comment on the basement membrane related glomerular disease on electron microscopy study. And thin basement membrane disease on electron microscopy cannot exclude Alport syndrome. Follow-up should be done to further exclude or confirm Alport syndrome. Thank you.
Thank you so much, ma'am. That was amazing. Um, Before we move on to, I I would like to present my apologies that I joined late and I couldn't introduce Bhavna ma'am to the best. So I would like to introduce her. She is the onco and nepropathologist. She is a senior consultant and head of the department of histopathology department at Newburgh Supratech Reference Lab. And she is based at Ahmedabad. I had interaction with her for a couple of times, and I am definitely 100% sure that she is one of the kindest nephropathologists that I have ever interacted with. It was never guilt, or it was never embarrassment to ask her any silly questions that I used to see in my patients. So, and I could see her calmness answering all of them all throughout time. So, thank you so much, ma'am, and sorry for all those annoying questions that I used to ask you. Um, Moving on to our panelist, I would like to introduce our panelist also. Um, the first panelist for tonight is Dr. Arvind Bagga sir, and I don't think that there is a single nephrologist or the person who is interested in nephrology who doesn't know sir's name or haven't gone through his papers or books. So thank you so much, sir, for joining tonight. It's a real honor and pleasure for having you here. The second panelist with us is Dr. Devesh Engineer sir. Sir is at IKDRC. He's a professor of nephrology. Sir, thank you so much for joining us. It's
Thank you.
been honor. We have appreciated your work for throughout our nephrology education and practice now. So thank you so much. Um, the Taking forward this session, I would like to have some questions for our panelists, and I would like them to enlighten us with their experience also. So first, I would like to start with Arvind sir. So I have calculated few of the questions. Next. So next. So in so the first question, sir, in teenager, when we see chronic kidney disease having proteinuria, hematuria, some of them do mention hearing loss with or without visual impairment. So in this scenario, is it sufficient to label Alport syndrome? Because we don't have a biopsy yet, we don't have a genetic testing yet, but everything else matches with the description. So is it like too obvious to consider, or should we still need a histopathology or like a genetic testing to call it?
I think it's a very valid question. Thank you so much for this opportunity to be here, and thanks so much, all of you. So, if you look at a teenager with hematuria and proteinuria and hearing loss, visual impairment is uncommon.
Okay.
Apart from considering Alport, one would have to consider the other syndromes wherein in which you can also have hearing loss. And one thing that we often discuss are the myosin heavy chain uh, syndromes, the Fechner and Epstein, and so on. There you could have hearing loss, thrombocytopenia, and so on. Uh, Hearing loss could also, be secondary to something else. So
Okay.
whenever you get, hematuria and proteinuria, it could still be a FSGS with hearing loss, say due to drug-induced injury or whatever. Then there are, other conditions wherein hearing loss may happen as a part of the CKD per se, but which are relatively uncommon, things like involving the PAX2 gene, uh, at times also some mitochondrial genes. But then hearing loss would be overall uncommon in most chronic kidney diseases with hematuria and proteinuria. So the suspicion would be high, but I would definitely want to have a definitive diagnosis, either in terms of genetics or a kidney biopsy, depending on what the facilities that one has.
Okay, thank you, sir. I would like to ask very one of the basic question also, that one of my patient who I was following for more than 2.5 years, the biopsy was suggestive of FSGS, and he had no hearing loss, no visual symptoms, and at that time there was no family history in the parents also. But when we when the patient reached ESRD, unfortunately we couldn't have EM at that time, but when we evaluated his brothers as a probable donors or prospective donors, all of them had a was not non-normal creatine. Creatine was like 1.7, 1.8, and at that time we had a suspicion. We got a genetics testing done and showed Alport, and it was very surprising for me because there were no other symptoms which were shown by the patient throughout almost 3 years of life, 3 years of period when he was with me and the follow-up. So is it possible that only few of the symptoms will be presenting, or like what we call as the classical synchronon, that all features need to coexist together? Can they appear at the different ages of their life?
Absolutely. So I think the initial features would be hematuria, which is usually microscopic, rarely gross, proteinuria, which would and occasionally the nephrotic syndrome. Uh, the hearing deficits may again be happening later. I agree, that if you've got a hearing deficit, then the outcomes are poorer. The kidney disease may progress faster. But hearing deficit may not always be there when children present initially. In fact, most of the children that we see who have Alport syndrome, initially they would hardly ever complain of hearing deficits. And it's only later, that these things would come up. Eye findings are even less common, but they are more specific. So if you get lenticonus or if you get something else, then clearly that's a far more specific association. But clearly, eye findings may be the least one that would come forward. So they need not be there together. And clearly, as ma'am said, things like leiomyomatosis, etc., they would totally reflect a totally different kind of a genetic disorder in which you also have the uh, Pol4A6 genes being affected. So clearly, that's a different thing, or even the MMEC syndrome, wherein you have other associations, and they would all be there in the differential diagnosis. So the short answer is no, they need not be there together.
Thank you, sir. I probably I should have asked this question before I started taking care of that patient, so that I would have like learned this. Do we have any reliable tools which is apart from histopathology? Because sometimes the patient may come to us that the kidneys are small, shrunken, the creatinine has already increased, and the patient may not be feasible for the biopsy. And obviously, the genetic testing is a little bit costlier. So, is it possible that we can have anything else which we can help us?
Obviously, if you do not have, if you cannot do a kidney biopsy, then you cannot rely on the electron microscopy and so on. And if you can't do genetics, it's a bit tough to be definitely diagnosing Alport. But as ma'am showed, that the skin biopsy may help in some cases. Although whenever we used it practically, obviously maybe it works well in your hands, ma'am. But clearly, at least at the institute, it's not worked very well. The skin and obviously the skin, the immunostaining would be only specific for the X-linked forms. It would not work very well for the autosomal recessive forms that would account for almost, say, 20% of all Alport. So the skin would be useful. As I said before, that the eyes findings are quite specific. So if you get lenticonus, if you get the dot and click retinopathy, or if you find, temporal thinning, they are quite specific for Alport. Deafness is not specific, deafness is sensitive, but it's not a very specific sign. So one can rely on these extra renal features apart from, other things. So I would think that as of today, genetics and or histopathology would really be the gold standards. Dr. Bhavna, what do you think?
Bhavna ma'am, what is your opinion?
Yes, I think nowadays everybody can get genetics test also done easily available, though the cost does matter. But only diagnostic test, if we can do instead of whole exome sequencing, we can just do clinical exome sequencing, and that will be cheaper, and then it can be diagnostic also. And of course, biopsy is always the gold standard still for the diagnosis, followed by EM.
But if we are so much like depending on the biopsy and genetic testing, whether there will be any negative predictive value. Suppose
So,
we are like biopsying the brothers of the patients and the same case I am discussing. But if is it possible that they never progress, or they is it possible?
It is, if it's the X-linked form, we do know that the X-linked forms do behave differently. Even within X-linked, as ma'am said, if it's a truncating variation, whether you have a nonsense variation compared to, say, a missense variant, or say a synonymous variant, and there are certain glycine variants that are not that bad, So clearly, you could have a variable phenotype, but within a family, I would imagine that the phenotype would usually be similar. And the majority of X-linked males would have a significant CKD by the time they are in 40s. Majority would be, it's more like 25, 30s. But by 40s, I would imagine a very large majority would be affected. The females clearly can present a bit late, can go into ESKD and so on much later. So I think one would have to trust this. Do remember that since you have this question, that could genetics be negative? The whole exome sequencing may at times be negative in about 15%.
Okay.
And so be aware, that you could have deep variants, you could have intronic variants, you could have variants in the regulatory part of the gene, you could even have copy number variations. So 85% is the overall figure in which you would pick up a genetic defect, even in histologically confirmed Alport syndrome. So in those cases, you probably need to do a whole genome sequencing, or you need to do MLP or microarray or something.
So still 15. So we will keep that.
The overall figure is close to 15%. It
Yeah.
varies between 10 to 15%, but I would imagine it's more like 15%.
We'll keep that number in mind, sir. Thank you. Thank you so much. Now,
Also, do remember, and in fact, ma'am had also said that, in fact, currently it's thought that the autosomal dominant Alport is the commonest inherited kidney disease in human beings. It's much more commoner than polycystic kidney disease. So, ADAS, or the heterozygous dominant variants, would happen in about 1% of the population. Now, whether it's always going to be significant or not, so again, this information is gradually becoming more and more discussed, that almost 1% of the population may have a variant in COL4A3 or COL4A4. A very small proportion will progress to ESKD. I agree. About 5% will progress to ESKD. But keep this figure in mind as well.
Yeah, it is related to because of the advancement of the detection system. Nowadays, we are doing next generation sequencing. Earlier, it used to be Sanger sequencing. So the detection rate has increased from 5% to now 20%. This is what they say because of the modality of the test what we are doing now for the detection of the Alport syndrome. Next generation sequencing is better than the Sanger sequencing.
oh, good. So actually, those unknown CKD, there are indications and list of situations where we do get exome sequencing. But at that time, I was not knowing about this such a significant population that we must be like looking around in our population. So thank you so much, sir, and thank you so much, ma'am. Now, I would like to involve Dr. Divesh sir also in this discussion. That so from this patient's diagnosis, which was made in childhood, we are aware that now they are having a Alport. So what modality we can use to slow down the progression and delay them from being ESRD or finding them on dialysis?
So in the Alport syndrome, we have very good study. Like it was like a PROTECT study that have demonstrated that if we started Remipil very early, means even in the stage of microhematuria, no proteinuria, then it causes significant slowdown the rate of decline and significantly decrease the risk of albuminuria, proteinuria, and further risk of end-stage renal disease. So even where we have that study even in the adults also. So what the most important thing is this study was at what time you are initiating the basically like ACE or ARB. So the PROTECT study was done with the Remipil. So what they were found was the earlier you start the Remipil, even in the patient with no proteinuria, it has significant advantage, and and even in the many studies they are like a study with a sibling also, where one sibling was started on the early therapy, and other sibling was started later therapy. So what were found with, if the patient was started on this Remipil in even in the early stage, like even in the microimmature state or even in the microimmature with microalbuminuria, it causes significant, even 10 to 15 days delay the end-stage renal disease. So I think to date, the most important therapy that has a proven benefit in the randomized controlled trial is basically like ACE therapy, ARB therapy. Second therapy with recent literature that has found to be some advantage is like SGLT2 inhibitor therapy. So here there are one or two studies. They are not big studies, but what they are observation studies, and what they have found is okay, in the patient who are on the maximum ACE-ARB therapy, and despite having that they having significant albuminuria proteinuria, in such patients addition of SGLT2 inhibitor significantly decrease the risk of proteinuria, albuminuria, and even delays even delays the end stage renal disease by decreasing the rate of fall of GFR. So the strongest evidence with the RCDs with the like Remiprin is therapy, and we have now some evidence with SGLT2 therapy also, and now they are going to they are even started like the double protect study. There is a randomized control trial study where they are going to evaluate the advantage of SGLT2 therapy in the patient already on having on ACIB therapy. So that will in future will tell us in better way.
Okay. So, sorry, the again I'll go back to the patient that I had. So biopsy was suggestive of FSGS because at that time EM could not be done. So, and I was just like worried about whether this is a primary versus secondary FSGS. And my bad, at that time I had never had a exome sequencing report with me, but I considered him despite of EM lack of EM and 4.5 gram of proteinuria. I started the patient on immunosuppression, and I still remember that the patient went into remission. So, any role of immunosuppression, or I was just partially being lucky?
As per the literature, there is probably no role of immunosuppression basically.
So that's probably the same thing happened. I couldn't have the
So
patient.
even I have one of my case where the young male 17 18 years was found to
Mhm.
have like a nephrotic proteinuria, no, not that much significant hypoalbuminemia. We did biopsy. The biopsy was reported as a MPGN. So we started the patient on steroid therapy. There was no response. Then we second line added after like 3 months morphylate. Still there was no advantage. At that point, we decided to do like a genetic study. And at that point, we found to pick up like Alport basically. So many times you can have like a very common is FSGS, but sometimes you can even have other manifestation also. So I think if the patient is not responding to steroid, I think it is better in a young patient. It is always better to have like a genetic analysis rather than subject him to further therapy with the immunosuppression.
Oh, that's a very important question. Sorry, that's a very important point which is we need to follow. And thank you so much for that. Seemaji, can I have the next slide, please? So now coming to the transplant, as I mentioned that he is being worked up for transplant. All his brothers are obviously not the best suitable candidate. So in this scenario, whether the father who is a 64-year-old wants to donate, um, the exome sequencing, as I mentioned, that Alport patient is already on dialysis. No other family member is coming forward. What best options that I can have?
So basically, it depends on which type of Alport. Suppose it is like X-linked Alport syndrome, then we are I think we are comfortable with the father basically. So there is no
Yeah.
issue here. Sir. The question only comes when it is like a autosomal recessive Alport syndrome. So, what practice we follow is basically uh, if it is X-linked, then we always try to avoid like a mother. If it is like autosomal recessive, then first what we do is we'll check for the proteinuria, GFR, and we check for the very ear or eye manifestation is there or not. And if they are if they are not there, then probably if it is like ages like a more than 45 years, then we are, I think, comfortable with taking. But nowadays, with the availability of genetic study, in all such cases where the patient recipient is like a confirmed Alport, we'll always like to do genetic study in the donor before proceeding, basically.
Okay, perfect. Thank you, sir. So, I when I was doing my nephrology, we always used to know that anti-GBM nephritis is common post transplant. So, is this how valid this is? Is it like very common that we see after the transplant, and is there anything that we can predict or like prevent? And if at all, if it is present, can we manage it?
So it is basically very uncommon. So the literature what suggests is like a 4 to 5% basically. So because of that, we should not avoid transplant in Alport syndrome because it is very uncommon manifestation. And regarding the what are the risk factors that can predict? So basically, whatever the literature is saying is it is mainly seen in the males basically. So if it's like it is a male Alport with X-linked Alport, then the risk may be higher. Risk may be higher even in the patient who has got a very early ASRD, like in the second or third decade. And even there are certain mutations that tells like a very large mutation that causes like a significant deficiency of call 4A5 will have an increased risk of like anti-GM disease. But till now, there is no single factor that can 100% help to predict whether the patient will develop anti-GBM or not, basically. So, considering that thing and very low risk of anti-GBM disease, we should not hesitate to do transplant in Alport syndrome.
Thank you, sir. So most probably it was the most favorite question of the examiners to ask in Viva. Probably that is the reason we could remember that anti-GBM. So that's something which was very essential to understand while keeping a transplant on card for these patients. Um, I think there are one more set of questions which I have charted. Seemaji? Yes. So what will be the key considerations when I'm trying to understand the best timing for the referral, whether to consider preemptive for this patient? Will that be good enough?
Yeah, we always encourage preemptive transplant, but that depends on the basically donor availability. Because in India, I think what we see, even in my practice, the most of the donor for this young patient, like those who are in 20 and 30, basically they are mother basically. And if we see in also in our cohort, the most of the basically X-linked Alports. So many times the mother cannot give the kidney, father are not willing. So that is the biggest issue that we are facing basically. So if they have like a willing donor, like in form of like an extended relative or father, then I think we should encourage them to have a transplant basically. But the biggest issue is basically like a mother is not going to donate, will not able to donate a kidney to the son, and basically, and many times the other male members, father are not willing basically.
Okay, but so obviously it's a real challenge at that time when such situation occurs. Um, Madam mentioned in her talk regarding the extrarenal manifestations also, not only the kidney but even the vascular, cardiac, ocular. So whether there will be like extrarenal features which can like ask for a referral early in the part of the disease progression, should we consider them that by doing
So,
a
so
transplant?
So there are certain features that can tell us that the patient is going to progress very fast. One thing is the many patients, those who are presenting with a very significant proteinuria with FSGS1 biopsy, they are going to progress very fast. Second thing is if the other family member is affected, that phenotype of that brother that can tell us ki how, because the disease is going to almost resemble same in the other sibling also. Third thing is, so as already told, certain type of mutations like a missense mutation, large frame shift mutation that will predict for a very high rate of progression of the Alport syndrome. So these factors, and so if the patient is having like a sensitive hearing deficit, that is also one of the risk factors for faster progression. So if the patient is having this feature, then they should be ideally in the very early care of the nephrologist basically. So we can intervene very early basically with like available conservative therapy.
Perfect. Thank you, sir. I'll just go through the YouTube to understand whether there are any questions for us. Seemaji, are there any questions?
Just a minute. I'll just check some.
Dr. Kumtekar, do you want to have any questions?
No, so we
So,
don't.
am I audible?
Yes, sir.
Yes.
Okay,
Better
fine.
now.
So, thank you so much. See, Alports, we have basically we are practicing adult nephrology, but somewhat on the twilight zone, we get patients say 18 years old or 20 years old or something like that. And these patients, when we biopsy, we find FSGS, and nothing comes out of it. Then we start immunosuppression as a maybe a knee-jerk reaction, and after that, when the patient doesn't respond to an immunosuppression, we on the back of our mind we start thinking about exome sequencing. We start thinking about some other tests like SUPAR or something like that. So my question is to Dr. Arvind Bagga sir. Sir, this genomic sequencing has come recently, like maybe 15 years or so. Next sequencing has come like 3 to 5 years ago. So what was in your times when you were dealing with such kind of patients, say maybe 20 years ago, and how was your approach at that time and how it has changed now? Like, do you think the genome sequencing and the finding the genotype of the patient may be important in coming years, or it's just the clinical acumen of the treating nephrologist?
Clinically, I think the answer is obvious. I think with the as you get more technology, it would help us. And so if you do have genetic sequencing, especially in patients with steroid resistance, who are so our current standard of care is that if you get a patient with steroid resistance, we would begin with a calcineurin inhibitor. So we begin with a CNI, and the ones who do not respond to CNI with the complete remission, we would advise that they undergo genetic sequencing. And you would be surprised to know that in our last, when we were trying to collate all our information, X-linked Alport syndrome is one of the commonest causes of steroid-resistant nephrotic syndrome. And this is data from not only India, but from Calcutta in India, from UK. So clearly, Alport syndrome presenting as FSGS that is not responsive to CNI is important. So clearly, I think the answer is very obvious that I think one would have to rely more on genetics to be able to define our patient population better. Having said this, there are some patients with Alport who do show a partial response to calcineurin inhibitors.
Yes,
I did
yes,
write that on the chat as well.
yes.
So I think one should be looking at a complete response rather than a partial response. So if the response is not complete, one should be more proactive in trying to get genetics done.
So in the same line of discussion, we are doing genome sequencing or finding the genotype only after we find it to be a steroid resistant nephrotic syndrome, or we are failing to achieve a complete remission with CNI, maybe a cyclo or a tacrolimus.
So
So
I think
can we bring up the genome sequencing upfront, like
you're right.
before we start immunosuppression, maybe a single drug like glucocorticoid or a combined immunosuppression like a CNI plus glucocorticoid. So do
You're
you think
absolutely
in
you're right.
future we
You are
may be doing it
absolutely right.
upfront?
You're absolutely right, sir. In fact, the KDIGO says that as soon as you diagnose steroid resistance, do genetics. The
Yes,
problem
yes,
with us is, that when you do genetics, you end up seeing a lot of noise. And when we have really sat down and looked at our nationwide data, the overall yield of genetics is about 20%. So 80% of
yes,
steroid resistance is still immune mediated, or maybe if 80% may be a high figure, maybe at least 75% of steroid resistance is still immune mediated. So when we do genetics, in all our patients, we may end up picking up a number of conditions which are VUSs, or which are likely benign or benign,
yes,
and then they're going to
yes.
get wrongly labeled. So as a policy, the Indian Society of Pediatric Nephrology said that we will do genetics uh, only if there is CNI non-response. But as I said,
Yes.
your point of doing genetics and all is also a very major advice, say by KDIGO and even by the IPNA. They would say do it in all. But I think be aware that be ready to accept the noise. Bhavna, what do you think?
Dr. Bhavna, your comment on this?
Yeah, actually, when I used to see so many steroid resistant nephrotic, on biopsy, and my morphological finding was FSGS, and we used to put a disclaimer below that they should go for the genetic testing. But unfortunately, in our country, the awareness of the doing the genetic testing and the cost factor, they both are the
Yes,
difficult
absolutely.
thing, to convince or counsel the patient. And that too, when we do at least for one patient, then again to convince for their relatives, because we have to see the complete genetic profile of the family. So those are the limitations of our country. And we have to bring more awareness in the society for this particular test. This is what I feel.
Dr.
That,
Divyesh sir, Dr. Divyesh sir, do you want to have comments on this?
Yeah, I think legally we follow the same protocol as Dr. Bagasa has said. Once steroid, then followed by CNI, and if no response, before adding third agent, always have genetics. So that also we are following.
Perfect. Okay. So,
when Dr. Bhavna has brought in the societal aspect, do you think an elaborate Alport registry will be helpful in Indian scenarios?
Absolutely. I'm one for these registries. I think we have not done very well across the. Look at what Europe is doing. US has also not done that remarkably, but Europe in pediatric nephrology has done registries on virtually all diseases,
All diseases.
and they have such strong bases, genetic bases. Clearly, you need to have champions within the country who are following up one disease or two diseases. These registries would definitely help give us information on the long term. Once you have registries, you can also plan trials. So, because otherwise, even at AIMS, you would have hardly 20, 30 patients.
Obviously,
You can't do good trials. But if you've got a
obviously,
registry,
obviously.
you collaborate. So clearly, there is the benefits of collaboration are very strong. So I have no doubt in what you are saying is right.
So the European experience of Alport registry and thalassemia registries and sickle cell registries is that they were used for premarital counselings. So it is one of the ways of preventing genetic disorders and bringing down their incidence. We may not be doing much for about their prevalence because that's maybe beyond our reach. But these registries are useful for the family counselings premarital. So do you think such a kind of thing will be applied for our society? We have so many cultural,
Yeah.
bottlenecks.
I think we should first begin to have, at least regional registries. I don't know whether we would be able to, the aim that you are saying may be tough, initially, but at least there should be regional collaborations, and I see no reason why people cannot collaborate, put their data together, and have good quality genetics, so that at least know what you are talking about.
Dr. Divesh, I have one small doubt for you. How many patients have you seen going into a partial remission with CNI uh, who are diagnosed to have an Alport? I'm not talking about the CKD of unknown origin or an FSGS of unknown etiology, but diagnosed Alport going into a partial remission with a CNI.
So I will not see this patient.
Dr. Arvind sir,
I
your
would
comment
imagine
on
very
this?
small numbers, very
Very
small
small.
numbers, because there is actin stabilization. It does stabilize the podocyte actin, and it would lead to some. But then I agree. Once we diagnose that a patient has a genetic etiology, we would not give immunosuppression. And I would totally agree with Devesh. That once you diagnose that there is an underlying genetic cause, whether it is Alport, whether it is NPHS2, whatever, we would take off therapy, because I think because then the message is distorted.
So, last question from my end. In the Middle East and Middle Eastern countries, there is a monogenic inheritance of some muscular dystrophies. And there has been very good data on gene therapies for these dystrophies. and they're particularly applied for monogenic inheritance. When we talk of Alport, it is definitely a monogenic. And so, do you think of any future possibility of something like adenovirus based or gene therapy for Alports? Has it been tried, or are you looking forward to it?
I think in the next few years you will see, there are at least two modalities. One is the inhibitors to miRNA, I think 21. There are some trials happening, and the other is exon skipping, and the
Yes.
and the CASP and whatever, I don't know the full form. The
This Casper scissors.
Yeah, the CRISPR Casper. So clearly, I would imagine that in the next 10 years, just like we are looking at, even NPHS2 mutations,
Yes.
you are going to see a change. So clearly, if picked up early and treated early, they are so in young, it will have to happen in the young. Doing it too late,
Yes.
you already
Yes.
have advanced kidney disease. But I'm quite
Some
sure,
sclerosis
genetic,
happening.
for monogenic disorders, there would be a way forward.
Dr. Divesh, your
It's
comment?
already happening in stenosis.
Right.
You have
Yeah,
therapies
I
that are kind of coming. Yeah.
yeah, I come across few studies where they use like a adenovirus based therapy to silence MI21 basically because it is one of the thing to like stimulate inflammation. But still, I think I have not heard of any clinical trial basically. So I think we may hear in the next few years.
So that
Over to you,
means that
Dr. Suhas.
so that
Dr.
means that
Suhas, over to you.
For Alport, there are still better days are yet to come, where we'll be seeing better diagnostics, better um, probably early diagnosis, and few modalities which will prevent the further progression or even halt the progression of the Alports. So with this, probably we are reaching our end of the session. I would like to sincerely thank Bhavna ma'am for taking the opportunity and enlightening us. Thank you. We will be troubling you. So thank you so much, ma'am.
Thank you.
Arvind sir, it was an like honor to listen to you. So thank you so much. Um, it was really like one lifetime experience to have that kind of discussion with you. So thank you so much. Divya sir, it is really nice that you accepted our invitation and you brought us all these good points for us on the table for discuss. So thank you so much. Thank you, Dr. Girish, and thank you all the listeners who are like joined on YouTube platform. With this, I would like to end this session. Thank you all the panelists again. Thank you so much.
Thank you. Thank you so much. Thank you.
Thank you, sir.
Nice.